Well, hello and welcome to Applying Lessons from Costa Rica to Equity-Oriented Primary Care webinar. Health Leads and the Equity-Oriented Primary Care team is so pleased to host this webinar today. I am Jacqueline Dalton, the Director of Community Engagement at Health Leads, and I have the pleasure of serving as today's webinar moderator. This webinar is the first in a three-part series, and our team will be dropping a couple of links in the chat to our project webpage and a recent blog post that shares some more insight regarding the purpose and design of the Equity-Oriented Primary Care Innovation Collaborative. Also, by registering today, you've already signed up to receive an announcement about future webinars in this series. Also, today's webinar is available in Spanish, and to listen to this presentation in Spanish, click the globe interpretation icon at the bottom of your screen and select Spanish. This webinar also has a closed captioning option, and to enable the closed captioning, please click on the closed captioning or CC icon at the bottom of the Zoom screen as well. A few other housekeeping items that we'd like to review today. Today's webinar will be recorded and sent to everyone who registered along with any materials shared during this time. During today's webinar, we'll have time to answer as many of your questions as possible, so please submit all of your questions using the Q&A button found at the bottom of your screen. Alternatively, you could use the Zoom chat feature to share comments, reactions, and links with our fellow attendees and panelists today. You're also welcome to maybe try out that Zoom feature now and let us know who you are and where you're joining from today. And I see some of those coming in on the chat, so thank you so much. I know we have folks joining us from all over the country and some from even out of the country. So we're so happy to have you all here today. And last but not least, at the end of today's webinar, we will be launching a poll and evaluation survey. So please take a moment to quickly share your feedback on today's webinar and suggestions for future webinar offerings. Excellent. So getting to our lineup for today's webinar, we have an exciting agenda set. I will give a brief overview of Health Leads Equity-Oriented Primary Care Innovation Collaborative, or EOPC, as we call it, and also the Community Integrated Health System concept. Then Hannah Radcliffe and Madeline Pesic will be bringing to life that concept with a demonstration of their research on integrated health systems in Costa Rica. They'll talk to us about the critical roles and accountability involved in this work, and also share tips for primary care organizations to design a more equitable and coordinated system of care for their communities. And we also have some links in the chat for you to read more about all of our speakers today, including myself. So those links are in the chat. Excellent. So next slide. So as we jump in today, and we can move on to the next slide, we hope that this discussion will help to inform on the issue of coordinated care and the importance of care coordination for patients and community members. So as I begin to talk about health equity and innovation in primary care, I want to share by first starting to define the concept of care coordination. Next slide, please. So care coordination, like many terms used in healthcare, can have many different meanings and interpretations depending on who you're talking to or what audience you have. So in 2018, the Agency for Healthcare Research and Quality reviewed over 40 definitions, some being very broad, even broader than the one that you see here today, and some more specific. But after reviewing those 40 definitions, they published this definition for care coordination, saying that care coordination is the deliberate organization of patient care activities and sharing of information among all the participants concerned with a particular patient's care to facilitate appropriate delivery of those healthcare services, which would then lead to safer and more effective care. Included in this concept is the idea that patients' needs and preferences are communicated to the right people at the right time, rather than the patient being the messenger of their own needs and preferences. In addition to this, the Institute of Medicine deemed that care coordination, this great idea of having everyone informed at the right time, is a key strategy to improve the American healthcare system and outcomes for not only patients, but also providers and payers. So next slide, please. In many ways, this idea of care coordination in the US healthcare system is still just an idea. And in fact, in this slide, you'll see different descriptions from in having own personal and professional conversations with various stakeholders. These are typically the descriptors that we hear when describing the US healthcare system. In many ways, they would say that care coordination in the US healthcare system is disjointed or unclear or inconsistent, confusing, and even a web of confusion at times, and exhausting to navigate. Also, prior to the pandemic, this is a lingering statistic that we hear, is that there's a lack of investment in primary care, with only 3% of the US healthcare spending going into the primary care sector. Patients presenting with unmet social needs, and along with not having enough time to address all of those social needs. And with this system being described as mostly expensive, repetitive, and convoluted, a convoluted journey of care. So in many ways, they describe a very fragmented system, not the idea of care coordination that I shared in my previous slide. And next slide, please. Here is one example. This is an illustration that you see on the slide right now. And this is an illustration of something called Daniel's Care Map. Daniel was a child who was living with a complex health condition called neurofibromatosis. And his mother was really challenged with having to coordinate his care. And so this care map really illustrates the complicated web of medical care and coverage, as well as the educational support and support services that Daniel's mother was receiving for children with complex medical needs. And so this was really the tool for Daniel's mom. It really helped her visualize all the different folks she had to be in contact with. And as you look at this map, you might think, this is a mess. But for Daniel's mom and for many Americans, having a map like this or a visual like this is really how they would describe and maybe even be able to keep up with all the aspects of healthcare that they have to interact with, even those services that they receive maybe at a school or another community-based organization that are helping them deal with the same and manage the same healthcare issue. So for many Americans, like I said, having this drawing, it might help them. And one idea that health leads always is looking to is, what would this look like? What would our healthcare system look like if we went upstream and to take an approach to be more coordinated and make this system easier to navigate for communities? So on this slide here, Health Leads, in building on our previous work, even prior to the pandemic, Health Leads was interested in how to continue supporting healthcare providers to meet the social needs of patients. And we knew a few things, right? We knew that building an equitable system of care requires investment and innovation. We did not want to build on already broken and convoluted system to make it even more confusing. So we wanted to take a method of innovation to go forth and redesign a whole new system. What would that look like on a small scale? Collaboration, involving all the essential players who need to be involved in this decision-making and redesign, including patient and community partners. So we also needed an aspect of engagement. And in having conversations with healthcare providers and also other community-based leaders who are essentially champions at the local level in their area or in their clinic or community-based setting, we heard 4 main themes. And those things are that sustainability and transforming care, especially primary care, happens at a systems level. So we needed to make sure that we approach this from a systems level. Secondly, that we have to set clear intentions for health equity. It's very often that health equity is something that folks want to address, but can easily get pushed to the back burner. So we have to set clear intentions that can be highlighted at each moment throughout the project. And so that's really important to us as well. And then prioritizing community and patient voice as a part of this redesign. In order to be following the needs of patients and have those preferences met, we know that this needs to be done with community voice at the table. And lastly, setting up the project or redesign for success through sustainability. And that's a key component of what we have today. And so we came out of our design of the EOPC project with 3 areas of innovation and how might we's. And they are, how might we unearth existing racial and institutional bias? How might we coordinate with community partners? And how might we apply a lens of sustainability to the work that's being redesigned to set the clinics up for success? And so on my next slide, you'll see we have funded 3 primary care clinics. And starting back in March of 2021, we funded 3 primary care clinics to go on this journey with us through the EOPC roadmap, which was the illustration that you saw on a previous slide. But it's a roadmap that takes us from this idea of unearthing these racial inequities that we are often faced with in healthcare and other sectors as well. But unearthing these inequities, really making an intentional purpose and using community voice to guide how the clinics are redesigning their care. And specifically, there's a cross-cutting concept that we're using, and it's the concept that we're discussing today of community integrated health systems. And to define that, it's integrated healthcare networks partnering with public health and community-based organizations, as I described, to reduce community health risk factors and provide coordinated care for communities who are experiencing the most adverse health outcomes this time. And so today during our discussion, what we're going to do is we're looking at another country's care delivery model. This idea of innovation doesn't say that we just brainstorm in our own box, but sometimes looking outside of the box. And so that's what we're doing today. We're going to talk with Hannah and Dr. Pesic about simply how they improved or made significant improvements in health outcomes with their approach to a community integrated health system model. And so now I'm going to turn it over to Dr. Madeline Pesic, who's an internal medicine and pediatrics postgrad year 2 resident at Brigham and Women's Hospital. And she also finds time somehow to be a primary healthcare research assistant at Ariani Labs. And then we also have Hannah Ratcliffe, who was a faculty at Ariani while doing this work, but now is also at Waymark. And we're excited to have them both doing our presentation today. So without further ado, I'll turn it over to you, Hannah and Madeline.
Thanks so much, Jacqueline. It's so nice to be with you all today. And just want to say again, thank you to you and the whole Health Leads team for the invitation. So I'm going to start out with just a little bit of kind of context about the work that we've been doing, although I should really say that this is work that Costa Rica has been doing. So Maddie and I and our colleagues at Ariadne Labs, which is based out of the Harvard School of Public Health and Brigham and Women's Hospital in Boston, we've spent the last 7 or so years trying to understand in great detail what Costa Rica has done, but can really claim no credit for their success, just trying to document it and share some of the wonderful lessons learned and pathways that they've taken to success. So if we can go to the first slide. I'd like to start by just giving a little bit of context about Costa Rica and its health system before I hand it over to my colleague Maddie to talk us through the exciting parts of this presentation. So Costa Rica is a Central American country with a population of about 5 million people. You can see it on the map here. It has a unique political history. It's been a stable socialist democracy since 1949. It has no national army. It's an interesting place in many respects. It's a middle income country, and it's had the majority of its healthcare delivered through public hospitals and clinics since about 1973. If we go to the next slide. So why are we talking about Costa Rica today? Why did Maddie and I and others start on this path so many years ago to understand what's been going on there? The answer is that Costa Rica has really been a primary healthcare exemplar for many decades now. So what we're looking at here is life expectancy in 1960 in blue and then in 2015 in green. And what we see is that in 2015, Costa Rica had the 3rd highest life expectancy in the Western Hemisphere at 80 years. If you go to the next slide. Costa Rica also has some of the best care coverage rates of any low or middle income country. on indicators ranging from appropriate treatment of diarrheal illness to antenatal care to vaccinations. And I know this data can be a little bit hard to read, but if you see the green dot on the kind of bar graphs at the bottom, that represents Costa Rica in the context of all low and middle income countries. And so we really see that it's a top performer kind of across the board. If we go to the next slide. We also have seen that Costa Rica is a top performer, has some of the best outcomes, again, among all low and middle income countries on indicators ranging from maternal mortality to under 5 mortality to adult mortality due to non-communicable diseases. And the next slide, please. And I think importantly, and one of the reasons why this has piqued our interest for so long is that Costa Rica has done this through relatively low expenditure. So you can see Costa Rica spends a little bit more on health than the Latin America region writ large, but much less than the world as a whole, and certainly much less than many high income countries like the United States that are not achieving as good of health outcomes. Next slide, please. And so, the question that we really set out to address all those years ago was, how has Costa Rica done this? What has led to these great results at such efficient cost? And so the work that we'll discuss today has shown us that Costa Rica has really achieved these great outcomes with such efficiency through an exemplary primary healthcare system. And this primary healthcare system is the first point of contact with the health system for most people, most of the time, for most conditions. And they've designed their primary healthcare system so that it delivers care that's coordinated, comprehensive, continuous over time, and people-centered. Go to the next slide, please. And so the primary healthcare system that we'll talk about today is the result of extensive reforms that Costa Rica undertook in the early 1990s. At that time, Costa Rica had a strong history of community-centric public health and primary care, but was facing a lot of challenges. The global recession in the 1980s and the subsequent structural adjustment reforms had resulted in reduced budget for public health and primary care in Costa Rica, as in so many other countries. And this was really exacerbated by inefficiencies in their system between the Social Security Administration, or the CAHA, which provided hospital-based care and some ambulatory care, and the Ministry of Health, which provided public health services and some preventive care. And so this idea of primary care was really being split across these two agencies, with things falling through the cracks and also some inefficiencies. And in the early 1990s, there was really a kind of devastating measles outbreak that shone a light on these issues and really helped build some political commitment to improving healthcare. And so at this point, I'll turn it over to Maddie, who can tell us about the journey that Costa Rica went on and where they've landed and how they've achieved these results.
Wonderful. Thanks so much, Hannah. And thank you so much to all of our colleagues at Health Leads for this opportunity to talk about this really exciting primary healthcare model that Costa Rica has developed. So Costa Rica took 4 main strategies in creating this new primary healthcare system that was born out of this reform in the mid-1990s. And they had 4 main principles. The first was that they really wanted to integrate the delivery of public health, preventive care, and curative care. And so in the United States, that would be almost analogous to the CDC combining with the VA or another healthcare delivery methods, and their primary care level would incorporate preventive, curative care, and their public health services. In order to deliver those services, they were going to use multidisciplinary teams, which we'll talk about in a little bit. To figure out who they were going to care for, they were going to geographically impanel their population to those teams. And then in order to make sure that the model was continuously improving and achieving the highest quality that it could, they were going to develop really reliable feedback loops to measure their performance. And this reform was developed initially by a small group of academics, both including physicians and public health experts. They looked at models from across the world and also did a lot of traveling within the country to see what models already existed that they could build on. And they then took this model to the community and to the public, and it was approved through a national law, meaning they really had to get buy-in from not only legislators, but a kind of community and popular opinion. Go to the next slide. So talking a little bit more about the integration of these public health and curative care services, the breadth that primary healthcare delivers in Costa Rica is incredibly impressive. So they're in charge of kind of basic curative care that we would typically in the United States associate with primary care responsibilities. So, you know, treating minor trauma, bumps and bruises, colds and sniffles, also basic health conditions like diabetes, hypertension that are becoming more and more prevalent. They're also responsible for carrying out preventative healthcare, cancer screenings, monitoring for the development of chronic conditions, and educating their population. But they're also responsible for epidemiologic surveillance and infectious disease control. So all of those things that in the United States kind of lie at different levels of responsibility are all under the purview of primary care. Go to the next slide. So the way that they organized this primary healthcare system was to use 3 tiers. And I won't belabor the point, but essentially they had divided the country up into 7 regions, those 7 regions up into 106 health areas. And health areas then oversee Ebis teams. And so Ebis teams are the primary unit by which primary care is delivered. And each Ebis team takes care of about 4,000 people. Next slide. So looking at these Ebis teams that are really the heart of the model, the Ebis teams structure does vary from place to place a little bit depending on the needs of the population, but every Ebis team has a doctor, has a nurse assistant. Most Ebis teams have their own community health worker. Occasionally they're shared between teams. They have a medical data clerk, which was a new position created by the reform. And they have most of the time a pharmacist. And together, these individuals work to deliver that primary care that is so comprehensive in nature we talked about before. So I really like this graphic depiction that Sophie Gibson drew. And I think it helps us to see kind of how the team might function in the community. So we will trace the journey of a young woman through her pregnancy, so you guys can get a sense of what this would look like in practice. So this young woman, we'll call her Joanna. She, up in the top right corner in the pink church, she learns about contraception and safe sex practices in community settings in discussions that are led by TOPS, sometimes nursing assistants and sometimes physicians. When she decides that she wants to get pregnant, she visits the Ebis clinic. She checks in with the medical data clerk who records her name on a list of pregnant women that the Ebis team will keep a close eye on. She has a check-in with the nurse assistant to get her vital signs and other measurements, and then has a consultation with the physician. She'll pick up any medications she needs during her pregnancy at the pharmacy. And then what's really innovative, I think, here is that when Joanna goes home, you can see her house in orange up in the top right, she will have visits from a community health worker where she will have her blood pressure monitored, she'll have her weight monitored. The community health worker will work with her to make sure that her home is safe, will connect her with social services if she needs help accessing heat, electricity, running water. And the community health worker can also deliver any vaccinations she might need during her pregnancy. And those can be given in the clinic or at her house. Go to the next slide. And a fundamental component, I think, of this model is a concept called geographic and panelment. And that's a fancy term for knowing who it is you're supposed to be responsible for and who it is that this Ebis team or primary care team is taking care of. And because this was the 1990s when they made the reform, they mapped out the entire country by hand and then assigned each person based on where they lived to an Ebis team. And so the graphic here just shows one of those original hand-drawn maps. But I think that the primary importance here is that the Ebis teams know exactly who all their patients are and then can be proactive about reaching out to them and helping them achieve their health goals. Next slide, please. Something else that was really critical to the reform that I think has enabled the long-term success of this reform over time is that there's a huge emphasis on collecting data, on using that data to improve health outcomes, to improve kind of procedures, and to be constantly working on getting better and better with each year and with each month. And so there are many, many different health data streams in Costa Rica between the Ebis team and the health area, the health region, between different governmental oversight bodies. And here in the graphic, we have one of these loops. So there is an annual quality investigation that happens at each health area level, so about 100 in the country. And those health areas are ranked from best to worst on health quality. That list is then published. There's no financial incentive for doing well or poorly on it, but everyone takes that evaluation really seriously. And then these kind of quality improvement loops are generated at the health area level with the quality improvement department at a national level to say, how can we do better next year? Not punitively, but really just with a focus on improvement. And again, I find, from an American perspective, we have often attach financial incentives to performance indicators. Costa Rica doesn't have any financial incentives attached to this and still really values these quality improvement processes and puts an inordinate amount of time into improving every single year. Next slide, please. So this is a huge undertaking that Costa Rica has done, and they've been able to sustain this model over the past 25 years. And so we looked at how did they do it? Like this is a huge lift to take a whole country and transform a primary healthcare system. And we found there were a couple important principles when they were implementing the model. And the first is that they started with an equity model and they continued with that equity lens throughout every step of implementation. So they started first in the most rural, underserved areas of the country, and then moved the model into the center so that folks who needed the most help from the model would get it first. They also made the take up of this model voluntary at first, so that the people who were starting it would be excited and engaged and willing to work with the implementers to work on any kinks that happened. Eventually, the model became compulsory, but not until 10 or 12 years down the road. And finally, there was a huge emphasis on community engagement at really every step of the implementation model that developed community health advisory boards at every health area to make sure that communities and patients were able to comment on implementation and voice their own personal priorities. Next slide. So one small piece that health areas do every 2 years is a health needs assessment. And for me, though it's a small part of all of the work that they do every year, I think that their commitment to this health needs assessment really speaks volumes about their commitment to the community. So each health area conducts a health needs assessment for their community every 2 years. And these documents that they create and the process and the man hours it takes to make these, it's enormous. These are 200, 300 page documents that are created each year that are really looking at what are the health priorities that we can identify as a medical team? What are the health priorities of the community themselves? For those problems that they identify, they're going to do a root cause analysis to see where they can intervene, at what level would be best to intervene at. And then they develop action plans at a health area level and then share those out with the community and say, does this sound right? You raised the problem of teen pregnancy. And that was a community priority for you. We had some ideas about how to decrease the rate of teen pregnancy, but we wanted to get your opinion and see if this feels like it would work for our community. So to me, this is a really important and beautiful part of the primary healthcare model. It's a small part of what they do every day, but their commitment to involving the community at every step and to doing such a massive undertaking every 2 years is really beautiful. You can go to the next slide.
Thanks so much, Maddie. So I wanted to just touch for very briefly before I hand it back to Jacqueline on some of the lessons learned from Costa Rica's model. And so I hope we can dive into some of this more in the Q&A, but very briefly, I think, what we've found through our work trying to document what's happened in Costa Rica very clearly, as we started out by saying, I think this community-based care and strong primary healthcare integrated with the community has improved patient health. It's improved outcomes, it's improved coverage, it's improved experience. The work in Costa Rica, also shows that integrating these public health and preventative and curative functions is possible. And I think that that's a really big take home. And I think particularly in the US, where these functions are so distinct and fragmented, and we've all lived that for the last 2 years with the COVID pandemic, the integration in Costa Rica is I think really something to emulate. Another lesson is that this community-based care and the integration are facilitated by multidisciplinary teams. These teams share data systems, they work as teams, they have shared responsibility for patients. These are not just people who are co-located in the same building. These are teams through and through, and those have been a huge driver of the success that Costa Rica has seen. The other piece is that these teams need a clearly defined population in order to know who they're providing their services to, and to be able to, as Maddie said, to shift their model of care from being one that's reactive and waiting for patients to show up in the clinic to one that's proactive and can really incorporate prevention as well as curative care. And then as Maddie was saying at the very end, all of this work in Costa Rica, we firmly believe the data feedback loops that they've developed, the shared data systems across teams, so everyone's looking at the same patient information, and the information about performance goes up the chain like we see in many, many countries and places, but it also comes back down, and it comes back down to the local teams to be able to digest for themselves, to be able to make action plans around, and to be able to use it on a day-to-day basis. And I think that's a really important lesson as well. So with that, I will conclude our portion and turn it back to you, Jacqueline.
Excellent. Well, thank you so much, Hannah and Madeline. This has been an excellent presentation. The model is fantastic to learn more about, even more than the discussions that we've had, as well as the information that you shared. It's just super informative. And so it lets us know that great things are happening in healthcare, and there are many great things to come as we learn more and more. So now we'll transition into our discussion. And again, for our attendees, please feel free to drop any questions into the Q&A feature. And we have had a couple come through. So I'm gonna go ahead and get us started with a couple of questions. There's one clarifying question where Gloria Dominguez in the chat was wondering why the terminology of person care was used rather than patient care.
Yeah, thanks, Jacqueline. I think that's a hugely important question, and I think really gets to the heart of what Costa Rica has tried to do. And so here in the US, we think about, I think too often, not everyone obviously, we think about medical care and we think about healthcare rather than health. And so we treat people as patients, and we don't necessarily care about them until they become a patient. But the term person-centered care or people-centered care is really meant to reflect care that reflects the needs of people in their communities, and when they're well, as well as when they're sick. And I think that's a really important distinction.
Yes, certainly. And that's terminology that in the EOPC project as well, we've been more so certainly trying to shift to a person focus rather than thinking about only patients, and being more inclusive of how we think about serving the needs of folks in our communities. So certainly. And then another question here also is Danielle Haskin is asking for you to talk more about who's on the health advisory boards. And this is a question that came through around the community health needs assessment slides.
Yeah, absolutely. So there are different community health advisory boards in different parts of Costa Rica. I'm not familiar with specific requirements of who needs to be on the board, but health areas will kind of make and create their health advisory boards with some latitude, I think. The community health advisory board meetings that I have personally attended generally had some patient representatives. They also have kind of municipal representatives, so maybe a city councilor or someone from part of the local government. And then they're also mainly open to the public, so anyone can kind of join the meeting or bring things up. I think importantly, doctors at the Ebis level, community health workers are also able to identify patients that they think would be great community advocates. And so I, met with one doctor who said that he had a great relationship with a 6-year-old patient who was looking for something to do during their retirement and cared deeply about the community, had grown up there, had lived there, and was looking for an additional opportunity. So he kind of nominated her to be a part of the board. And she's been an integral member of their medical community and moreover their community as a whole for the last 10 years. So I think it does depend from health area to health area, but it is really meant to be reflective of the community that the health area is serving.
Excellent. Well, thank you. And so now really jumping into our discussion a little bit more and thinking about the last slide that you shared, Hannah, I'm wondering how both of you, from your own perspective, might answer the question of, from those lessons learned that you shared about the Costa Rica model, how might some of those lessons tie into the issues that we see emerging in the U.S. healthcare system today, whether that's the community-based or integrated preventative and public health? What are some things that you see where there's definitely a tie for learning here?
Yeah, thanks, Jacqueline. I'll jump in, but Maddie, please add on. I think when I think about what issues is the U.S. healthcare system facing today, there's obviously many, but the ones that rise to the top, I think, are really ensuring meaningful access and meeting patients where they are. And during COVID, that's increasingly looked like telehealth as well. But I think that the kind of underlying principle there is meaningful access. I think we're also dealing with an aging and increasingly complex population. As I mentioned earlier, we have this kind of rift between public health and medical care that I think has really diminished trust as well. So it's led to ineffective care. It's led to many ineffective COVID responses. But I think we're seeing the trust breakdown play out kind of day after day. And then we're also, I think, really grappling with how do we address meaningfully the social determinants of health and address worsening equity gaps, which I know you're well familiar with, but we see that in everything from maternal health to chronic diseases. And so I really think that each of these issues is something that strong primary health care that's based on the C's that I talked about, that's coordinated and comprehensive, it's person-centered. Primary health care is something that at its heart can help mitigate most of those issues. Many of you have probably seen the National Academies of Science, Engineering, and Medicine came out with a major report last year that had, I think, 5 aims geared at strengthening primary healthcare here in the US. And their recommendations are all really in line with what we've seen in Costa Rica. Building teams that care for people and not diseases, making sure that these teams are part of the community and that they're connected by technology and data that's empowering and not burdensome.
Certainly. Thank you. And Madeline?
Yeah, as a primary care practitioner in Massachusetts, I think the hardest part is not the diagnosis of a disease or even the treatment of a disease. The hardest part is making sure that my patients can access those treatments, that they can access the services that they need. And it requires an enormous amount of activation energy for patients to get connected with a therapist if they're having mental health problems. It requires a huge amount of work to get and obtain health insurance. And so I think that looking at where we can reduce the burden on patients to put in so much hours and hours of effort, and where we can become more proactive about delivering the services that we know patients need to them where they're at, is really important. So I've found, care coordinators a really helpful piece of the puzzle in the United States to help patients navigate our very complex system. And ideally the system is more integrated with each other and is not as complex to navigate. But while we have this very complex system, I think patients need assistance with that to help navigate those bureaucratic hurdles.
Yes, certainly. So I'm hearing definitely the meaningful access part and getting to know who you're serving so that you can be addressing any kind of issues that they're experiencing even outside of the clinical walls. And I hear you saying the issue of, or the support of coordinators is key to helping folks navigate this healthcare system that we have now that we know folks need to use and sometimes may go underutilized if it becomes too complicated to engage in. So definitely. Okay, and then also I'm wondering for folks who are attending maybe from a primary care organization or maybe a community-based organization that provides any kind of health services and wondering how can they maybe take the first step to get more connected or more coordinated with the partners that they work with. Maybe there's some referrals, but not necessarily that coordinated connection. What might be the first step that they would take to go towards building a more or designing a more coordinated system for care in their local community? For either one of you, whoever wants to go first.
I can start again, Maddie. Sorry. So I think the first thing that comes to mind, as you just said again, Jacqueline, is really defining the community, and I mean that both in very practical terms, but also so that I think the first step is figuring out what your community needs, and what are those resource connections that they need. What are their kind of main issues, not necessarily just from a medical or clinical standpoint, but what are the problems that the community is facing? And I think that's a hyper local set of issues, and is something that it's dangerous to make assumptions about. And once you know what the community needs, I think again, I keep coming back to this idea of care teams and data flows that are really purpose built to meet those needs. And so maybe that looks like something like we've seen in Costa Rica. Maybe it looks totally different depending on what the community needs. We've done some work in Estonia where they've made really effective strides at care coordination with just a doctor and a nurse. They don't have a community health worker. They don't have the kind of medical clerk type position, but they've been able to make some really meaningful progress. And then we see places like, the South Central Foundation in Alaska that have really complex, large multidisciplinary teams, and they're tackling a whole other set of issues. But I think to me, what's really important is starting with the people and the resources that you have and building from there.
Definitely. And Madeline, would you add to that?
Yeah, I Hannah and I have been brainstorming for many years together, kind of what it looks like to bring back lessons from Costa Rica. So I'm in complete agreement with everything she said. And I think for healthcare practitioners, the first step is really a mindset switch. And I think medical education is moving toward this little by little, but fundamentally medical practitioners are asked to think about the patient in front of them, that makes it to their clinic, that sits down in front of them and says, I have an issue. And I think we've made some strides in saying, okay, your job is not just to address issues that are, I have high blood sugar, but I have trouble accessing healthy food because I can't find affordable food in my neighborhood. I'm having trouble managing my asthma because I need help cleaning the house or the apartment that I'm staying at. So I think we have made strides in expanding our definition of what we need to be helping our patients with. But again, it comes back to that question of who are we serving, and how do we as practitioners not just be reactive to whoever gets to us and makes it through our door, but how do we, once we know who we're trying to work with and help, who is that population, how do we become more active about meeting their needs? And those steps that Hannah outlined are really important. But it's a pretty big switch as a healthcare practitioner to feel responsible or to act on behalf of people who you've never met, who've never come to the clinic, who've never reached out to you.
Yeah, so definitely making those connections and getting to know folks, relationship building even is maybe a key first step. in shifting to a more coordinated system that's serving patient needs. And exactly what you mentioned there about, healthcare providers having that shift, and mindset, being proactive, right? Not waiting till you're in the clinic room and being faced with these needs. You don't have time to address them, but thinking about it proactively before this happens, what could we do to change and shift? Excellent. So and I'm also thinking about, for folks who are joining that are community leaders, maybe even patients themselves, folks who are not healthcare providers, what would you say as what's their role to play in this work, this idea of care coordination?
Yeah, Hannah, I can start with this one. I think it's twofold. For me, I think that they are an incredibly important aspect of this care, and it's also I'm always careful to not put the burden on folks who may already be busy with their jobs and their existing life and burden. And so it's a tough balance between asking community leaders to get involved, asking patients to become more involved, but also that this is work that the medical system needs to do, and community liaisoning is work that we need to make sure we're compensating folks for appropriately. So that being said, I think that working with community leaders, working with patients themselves, meeting and understanding who is treating folks in your area, where people are seeking their care. Again, it's about defining that population that you're going to have a relationship with, because before you do that, it's pretty hard to address who are the healthcare practitioners you want to partner with, if you're not even sure what practitioners are taking care of what part. So I would say that it's a critical liaisoning and partnership that has to happen, and it's tricky if you're not geographically in paneling, or if you don't have really clear definitions of populations. Yeah.
I think you nailed it, Maddie. Nothing else to add, really.
Excellent. All right, great. And so, I really understand that balance that you're talking about. And, one of the things that we're doing in the equity-oriented primary care is making sure that folks who are being engaged are properly incentivized. And, so I'm wondering, are there any, what's been your experience in this work with how you've seen other folks who are involved in this work of care coordination? What are some ways that folks are incentivized to be a part of this work?
I think there's a lot of now increasing global evidence out there. When I think we often think about community health workers as kind of these primary care coordinators. That's obviously not always true, but there's a lot of evidence now, and the WHO has recently come out with new guidelines for community health worker programs. I'm sure you're familiar with them. And I think one of the primary guidelines is that community health workers are a cadre, a profession in their own right, who need to be paid and formally employed. And so that's not to say that there's no incentives for anyone else, but I think especially in the global health field, for a long time, we've relied on this idea of small incentives or volunteer work, and that can be really powerful and amazing. But I think when we're talking about community health workers playing the as expansive and as specialized and professionalized a role as they do in Costa Rica, and as we are often asking them to do as care coordinators, making sure they're employed, making sure they're paid, making sure they're integrated into teams, I think is a really critical component.
Thank you. And I'm just going to go over to the Q&A here to see, we have quite a few questions here. And so Alex Haddad is wondering if there's been any consideration to adding other healthcare providers to this team, such as physical therapy, rehab professionals. What has been your experience in seeing, different disciplines involved in care teams?
Yeah, absolutely. So beyond the 5 core members, those additional support staff usually come at the health area level. And so the health area employs additional professionals, again, to support the needs of the community that they're serving. And so, different health areas that have a higher percentage of elderly people may employ 2 physical therapists at their health area instead of 1, or health areas where their health needs assessment has revealed that working with substance use disorders is a priority for the community. They may substitute their funding for a physical therapist for a specialized either psychiatrist or psychologist in helping folks to manage and navigate substance use disorder. So the additional professionals really come in at the health area level, but there's no strict rules about what each health area must employ. Most provide some sort of emergency care. Most provide some sort of more specialized pediatric care. Most provide some sort of more specialized gynecologic and obstetric care at the health area. But then it's really based on the needs of the community from there. So that's where I've seen physical therapists come into play. But certainly there's a need for additional allying there. And I think we're seeing as a global population ages and as folks spend more time in the hospital, the burden for folks to get rehabilitated from their deconditioning in the hospital is only growing and growing. And so I think it'll be an area for growth for Costa Rica to be able to link those kind of post-hospital care services with their health areas.
Yes, certainly. And I see in the chat also, Hannah, thanks for answering the question from Athen about the size of the patient population that was being cared for in Costa Rica. So still pretty extensive, but definitely takes a team of people to be addressing and coordinating amongst each other. So definitely. And then we have Mary, who is wondering if you, either you could talk a little bit more about the healthcare financing structure. How is it supported or not supported? How does it work?
Maddie, do you want to start or do you want me to?
Yeah, I'm happy to start. So I think that this is a really key part of making these comprehensive models, is that funding comes from one source. So there's one pot of resources that is the same pot of resources that's paying for hospitalizations, that's paying for rehab stays, that's paying for primary care, that's paying for emergency care. And so when you get returns at decreased hospitalizations or decreased emergency room utilizations, you're able to utilize those savings and see them at the primary care level. Whereas systems that are more fragmented, those financial incentives are not always aligned together. So the financing comes from a national system for health insurance, and all Costa Ricans need to be part of this health insurance. There's different contribution levels based on your income. So there's a certain group of folks who are enrolled in the health insurance at no cost, another group based on income that contribute more as they can. But universal health coverage and making sure that all Costa Ricans are covered by their public health insurance is a fundamental underlying part of this model. And then the Social Security Administration collects that money and then allocates it to different layers of primary care, secondary care, tertiary care, and so forth.
And Maddie, I think it's correct that there's very little or no fee for service, right? In Costa Rica, it's more of a capitated payment, which I think gets to this anonymous comment as well about how hard it is on a kind of fee for service type model to cover all of these types of things in a 15-minute provider visit. And so moving away from that fee for service model, moving tasks that don't need to be physician-led away from the physician, so that those 15 minutes, you know, it's time's always going to be scarce. So being able to use those for the things that really need a physician, and being able to use community health workers and nurses and others to take on some of the other pieces, I think is really an essential part of kind of what makes all of this tick as well.
Yes, certainly. So, you know, I hear a few things, and mostly underlying that the initial thing you mentioned, which was access, having meaningful access and making sure that patients have that access, as well as maybe shifting the way that we do things currently and thinking about how we might do them differently to be more efficient. Like what you just mentioned, Hannah, you know, maybe it's not the doctor who has to give this test. Maybe it can be, you know, another practitioner or other community health related individual. Maybe it's not in the clinical setting. Maybe it's at someone's home, right? Like we saw in the model of Johanna. So this has been an excellent conversation. I really just want to thank you both so much, both of our panelists, for sharing your expertise today. It's been a pleasure for me to be a moderator and to hear more about this model, and even learn about how this model could tie into the US healthcare system and how we might be able to retest or rethink ideas that are currently standard in our healthcare system. So again, thank you so much. And thank you to our attendees. Again, I want to share a reminder that today's slides will be shared, and a recording of the webinar will be posted online. A link will be provided in a follow-up email to you. But at this time, we're asking that you please take our post-webinar survey and let us know your feedback, your thoughts for future webinars and topics that you'd like to see. And again, thank you so much for your time and participation today. Everyone, we hope that you enjoy the rest of your day. Goodbye now.